Dr. Dangayach, first of all, thank you very much for joining our program. It's really highly appreciated, and it's an honor for us to be able to get access to the best of knowledge in this important area. I have a few questions to ask you. So the Mount Sinai Hospital is known as an epicenter of COVID epicenter in New York City, which just a few months ago just astonished the world and experienced tremendous spike of COVID-19 patients. I remember there were about 800 deaths per day in New York City at that time. The situation now seems under control. How many new COVID cases are in New York now, and how many severely ill patients do you see in your hospital every day, in ICU and other parts of your hospital?
Thank you so much, Almas, for this opportunity to speak to you. The honor is all mine. So at the peak of COVID-19, New York State had upwards of 11,900 patients that we saw in a single day. And at that time, Mount Sinai had upwards of 2,000 patients that were admitted. And in the ICUs, the peak that we had seen for the entire health system, about 600, 700 ICU patients at the peak. We had several ICUs that were adult ICUs pre-COVID-19, and then we had to literally double up our capacity to take care of these patients. As an example, for Mount Sinai Hospital, which is one of the hospitals within this large health system that has 8 hospitals and 7 affiliate hospitals, so we're one of the largest health systems in the United States right now. And at one of the largest hospitals within this health system, which is the Mount Sinai Hospital, that has about 1,100 or so beds, at the peak of COVID-19, we had to increase our ICU bed capacity from about 96 beds to 233 beds. And that meant providing ICU care in non-traditional ways. We had to double up some of our ICU rooms. I was part of one of the ICUs where we had to double up our ICU rooms, where a room meant for one patient. We had 2 patients that we were taking care of at the same time at the peak. So that was a very, very tough time for us. Since then, the situation has improved tremendously, and the total number of cases from that peak of 11,900 new cases per day in New York, we have now come down to about, there are about 700 or so new cases, and of those 700 or so new cases, these are numbers from yesterday, there were 125 cases in New York State. 125 patients were in the ICUs. And then specifically for Mount Sinai Hospital, we have about 6 patients who are PUIs, and we have very few patients who are in the ICUs, and a total of about a little upwards of 100 COVID-19 positive patients who are not in ICU settings.
Yeah, I'm glad to hear that, because I remember a very frightening situation when Mount Sinai set up the mobile hospital as a central park. So they put tents because there's not enough space for severely ill patients.
Absolutely. And then we 7 adult ICUs, and we went up to 11 ICUs. So that was in addition to having the tents put up in Central Park.
Now it's been a lot of discussion about reinfection by COVID-19. So it's been several months since you experienced this spike. Have you seen any reinfection cases among the patients that admitted to Mount Sinai?
Not that I have seen any COVID-19 reinfection cases personally, even in terms of reporting. So there were some patients who had COVID-19 test positive, weeks out from their initial infection as well. And this was very similar to the situation that was described first by South Korea, where there's some shedding of the dead virus particles, which is giving that PCR positivity. So that's essentially what we saw as well. Although I am not personally aware of any reinfection cases at Mount Sinai, we are aware of that reinfection case from Hong Kong, where the genetic material that was tested was different as compared to the original virus strain that this patient had suffered from. suffered from. So that was a true reinfection. We haven't seen anything of that sort yet.
Very tough situation. New York is over, and Mount Sinai, I think the first in the United States, established post-COVID care unit. So could you explain what is the definition of post-COVID state? How long symptoms should persist after the onset of first acute signs of COVID-19 for conditions to be qualified as post-COVID-19 state, or protracted symptoms or chronic condition?
It's a very good question, and we're very proud of how Mount Sinai responded both to the acute crisis as well as the forward thinking programs that Mount Sinai helped put together for the care of COVID 19 patients. So, if I may, I'm going to break down this post COVID 19 state into some categories for us to be able to wrap our heads around what to expect. So, from a scientific perspective, at least the papers that I have read so far and our own experience, there really isn't a clear timeline beyond which we can define a chronic COVID 19 state. And that is also a product of the fact that follow-up services in different parts of the world, follow-up services, even our own follow-up services, where we're beginning to see a lot of different flavors for what persistent or chronic symptoms could look like. So we haven't seen a very concrete definition in literature for what post-COVID-19 should be defined as. So having said that, though, if we think about the types of COVID-19 patients that we've taken care of, there are patients who develop symptoms but who are not sick enough to be admitted to the hospital. So those kinds of patients still need monitoring so that we can determine when do they need to get admitted to the hospital. So for those patients, Mount Sinai developed this program called the Precision Recovery Program. And this Precision Recovery Program is led by two co-directors, David Petrino, who's the specialist in physical rehab innovation, and Dr. Christopher Kellner, who's a cerebrovascular neurosurgeon and a specialist in precision recovery. So the two of them build this precision recovery program. And as part of this, they have been enrolling patients who were never admitted to the hospital, providing them with remote monitoring, including pulse oximetry, enrolling these patients into an app where patients report their symptoms. So from their program, we know that there are patients who never got sick enough to get admitted to a hospital, but are continuing to report persistent symptoms for weeks. So they have thousands of patients enrolled in this precision recovery program. And some of the patients have reported persistent symptoms all the way up to 2 to 3 months, despite not being sick enough to need to be in a hospital. And the kinds of symptoms that patients report are difficulty in thinking, persistent problems with their taste or smell. A lot of patients are reporting fatigue. In addition, anxiety. So that's one type of persistent COVID-19 symptoms. The second type are those patients who get admitted to a hospital but never get sick enough to need ICU level care. So that's about 80%, 85% of our patients are going to fall in that bucket, where they're going to need close monitoring in our wards, but they're not going to need ICU level care. So in those patients, for those kinds of patients, and then that population of patients, so about those 15 to 20% patients who get very, very sick and who require ICU level care, who develop this severe COVID-19. So we've developed pathways for follow-up across the board for patients now. So the Precision Recovery Program is seeing all these patients who did not get hospitalized. The COVID-19 Center, which is the first of its kind that brings together multiple subspecialists, right from internal medicine, pulmonology, cardiology, neuropsychology, physical therapy, occupational therapy, immunology. So a lot of different specialists have come together. This center was coordinated by the Department of Medicine, and the center's director is Dr. Zijian Chen. And what they have done is coordinated with all the different pre-existing programs that were providing longitudinal follow-up. Because as we can imagine, a lot of our patients who were admitted to the hospitals and who required ICU level care already had a lot of other comorbidities, had already required follow-up for other medical problems. And then you superimpose COVID-19 on that. So they're going to need additional follow-up, both for their chronic condition COVID-19 and the consequences or the complications services for these patients was then formed under this COVID-19 center. This COVID-19 center has been in place now for a couple of months, and the goal of that COVID-19 center is dual. One, to serve as this center to understand what is chronic COVID-19 and to contribute to literature in ways that can help other programs and countries to develop the kinds of services that COVID-19 survivors are going to need. So that's one of the goals of the COVID-19 center. And the second clinical trials for COVID-19. And those patients also require very dedicated follow-up, both from a trial perspective and from COVID-19 persistent symptoms perspective, or the complications of COVID-19 that they develop. So both from a clinical research perspective, so all those patients who were in clinical trials, they get follow-up, and all those patients who were hospitalized or were in ICUs get follow-up. The program that I specifically run, along with our co-director Miguel Martillo, is specifically a critical care recovery clinic for both COVID-19 and non-COVID-19 ICU survivors. So there we focus on of post-intensive care syndrome, which are the unintended consequences of critical care in the physical domain, in the cognitive domain, in the behavioral domain, where patients suffer from weakness, from fatigue, from depression, PTSD, anxiety, difficulty in sleeping. So that whole conglomerate of symptoms is together called as post-intensive care syndrome. So our anticipation was for COVID-19 ICU survivors, we are going to see a lot of patients with PICS. At the same time, is the burden of PICS going to be more in these patients as compared to the non-COVID-19 critically ill patients? That's something that we don't completely understand yet, but our center, as well as several other centers in the United States that do this kind of follow-up for critical care patients, is continuing to study that. And then we also refer our patients back into this network that the COVID-19 center has created.
Great. So, Dr. Dangayach, so how common is post-COVID-19 condition? There are different numbers. So I've heard that it's about 30% according to CDC, I guess. And I think British Medical Journal reported 10%. So what's your number?
It's difficult to just put a number because and I do agree with this range, because what do we even define as post COVID-19 state? Because those symptoms that come from, so the initial symptoms that a patient develops as part of COVID-19, as we're well aware, can span everything right from headaches, fatigue, to anosmia, dyschezia, problems with the lungs, and every lungs, the heart, muscles, everything is getting affected. Because everything is getting affected, what is the trajectory of recovery of each of those different kinds of symptoms? We're still beginning to understand that. And there are some good contributions in the literature looking at each of these different kinds of symptoms and for how long can you expect these symptoms to last. Having said that, there are secondary complications that come from COVID-19, and there are complications that come from as a consequence of our treatments as well. So how long does it take for both of those things to resolve? A good example would be those patients with COVID-19 who are sick enough to come to an ICU and then develop severe ARDS, even from the pre-COVID-19 ARDS. So ARDS is essentially this massive inflammation of lungs, and eventually
Respiratory distress syndrome.
exactly this respiratory distress syndrome that requires very dedicated, aggressive management. And in the pre-COVID-19 world, we've had so many good studies looking at what patients with ARDS, this respiratory distress syndrome, need. So applying some of those principles in the ICU, we know that what has been described for the post-ARDS survivorship, a large study that had looked at the cognitive consequences of ARDS, says that these patients do have a risk of developing premature problems in their thinking and in their cognition, and sometimes and these can persist even a year, 2 years, 3 years, 4 years out from the initial ARDS episode. Is that what's going to happen to COVID-19 ARDS survivors? Still needs to be studied. So we don't completely understand that. We know that some things that might happen for sick patients who are in the ICU. They're bed bound, they're getting sedation, they're getting neuromuscular blockers. So essentially medications that are needed for paralyzing patients so they can tolerate some different kinds of higher settings on ventilation, or they may need different kinds of therapies like steroids, or therapies that specifically work on our immune system. Having said that, some of the problems that are going to persist in COVID-19 patients are going to be consequences of just being critically ill. And some of them are going to be consequences of the kinds of treatments and therapies that they required so they could survive. Is it worth trying to tease out what the symptoms what are the persistent symptoms coming from? In some ways, to keep it really simple, I think what we've got to be prepared for is to take care of these patients after their discharge, is to be prepared to provide the kinds of services that they're going to need for continuing this journey of survivorship, both from COVID-19 or their hospitalization or their ICU stay. And that survivorship requires multidisciplinary management. In that multidisciplinary management, right from subspecialists to a multidisciplinary recovery team, PT, OT, speech, nutrition, so on and so forth. So I think not knowing the exact burden of this post COVID 19 state makes it harder to plan for that state of recovery. But if we learn from our experiences of patients who have been in these different kinds of settings from other illnesses, at least preparing to provide that kind of support and resources. So the CDC number of about a third or so patients will experience persistent symptoms, and the 10% that's mentioned, there was another French study that also had a ballpark number between 10 and 30% as well. So knowing from this experience, at least ramping up some of these resources to accommodate the surge, the wave of survivors that we're seeing from COVID-19 is important.
Thank you. So you already mentioned some symptoms such as neuralgia, then fatigue syndrome, anosmia, and lots of other things, of course, coronary heart disease. So could you summarize what are the most common symptoms of post-COVID situation that you observe and how your team manages them?
So for post-COVID-19, some of the common symptoms that patients are reporting, fatigue is definitely something, irrespective of how sick someone's been, irrespective of those three sort of flavors of COVID-19 that I mentioned. Patients are reporting on a lot of fatigue, that they're not able to do their regular activities. Persistent anosmia and difficulty with taste is also being reported. Um, for patients who've been sick enough in an ICU setting, uh, in our own experience, we saw about anywhere between 30 to 50% patients are reporting either depression, anxiety, or post-traumatic stress disorder. Symptoms that put them in the clinical category of post-traumatic stress disorder. So that psychological burden of COVID-19 is as big, if not if potentially if not bigger than what was being described for pics in patients who were previously critically ill. So what we anticipate specifically for long-term lung recovery. So what happens to patients who keep developing, they're continuing to recover, but they're still having some difficulty in breathing. So how often should we be imaging them to see if they've developed some fibrosis in their lungs or not? So from the SARS experience and from the MERS experience, we know that some patients, about 10 or 20% of these patients, could develop persistent lung fibrosis uh, once they've, particularly in the patients who were sick enough to be in an ICU setting. So the advice that we have taken into account is these patients are going to need to be monitored. when should you re-image them is variable. Going from the SARS MERS experience, the median time that these patients were getting a repeat CT chest was about 46 days or so. So you don't want to image them so early that you're still seeing persistent inflammation from their first episode, but you don't want to image them so late that you miss that somebody is developing a chronic pulmonary process. And then similarly for prothrombotic complications. So when we say prothrombotic, essentially those complications that are leading to clots in the brain, clots in the lungs, clots in the heart, clots in the legs. So those kinds of prothrombotic complications, or involvement of the kidneys by way of clots. So we know these clots can form anywhere. For patients who were diagnosed with a clotting problem during their hospitalization, irrespective of where the clotting problem was, whether it was a stroke, heart attack, or DVT, so clot in the legs or clot in the lungs, uh, some of those, so selected patients are going to need outpatient anticoagulation as well. And our approach to anticoagulation, so once you've diagnosed a clotting problem, based on the type of clotting problem, they're going to need at least 3 months of anticoagulation. And that is very similar to what we were doing for the non-COVID-19 patients as well. If you diagnosed a clot in the leg, 3 months of anticoagulation, very much in line with what the American College of Chest Physicians recommends doing. So essentially, in those patients, it's pretty clear. But for patients who don't have a diagnosed clot, but who have these blood tests that show that somebody might have a potentially higher risk of forming a clot, like this D dimer protein. If a D dimer is high, should you then be anticoagulating them in the outpatient setting? So this we at the peak of COVID-19, we were sending patients out with anticoagulation by way of an oral anticoagulant, unless there were any other contraindications, like rivaroxaban, or so using a oral anticoagulant for up to 2 to 4 weeks from their discharge. That is what we were doing when we were seeing these big numbers of COVID-19 patients. I think now that we're seeing fewer patients, there may be some changes in how we will address, and there's also evolving literature. I mean, the literature around COVID-19 has been tremendous. There are more than 35,000 pages papers on PubMed alone on COVID-19. So yes, we're learning a lot, and as we learn a lot, we need to adapt our approach. So I hope this answers that question, like what to watch for. And then those patients who have chronic conditions, underlying chronic conditions, what do we mean by that? So whether they already had coronary artery disease, or they already had heart failure, they had strokes in the past, or chronic lung conditions, or patients who are immunocompromised, patients who receive transplants, or who have underlying rheumatological disorders for which they're on medications, or patients with cancers, those patients are going to need this additional layer of monitoring, where you guide the patients in the symptoms to watch for. So those kinds of symptoms would be any new difficulties in breathing. If somebody was already on oxygen, now they're requiring even more oxygen. So alerting their care team that that my underlying symptoms are worsening, whether it's a patient with heart failure, whether it's a patient who has chronic lung conditions. And then specifically for those patients who are immunocompromised, the threshold for either having them come to an emergency room to get evaluated, or have more frequent follow-ups, I think should be low. With COVID-19 and social distancing, we're not being able to see our patients in person as frequently as we would have wanted to. But we're leveraging telehealth. And there's been this massive surge in telehealth resources. And that's if there were some blessings from COVID-19, I think one of the blessings from COVID-19 has been telehealth. And being able to
Exactly.
connect with our patients irrespective of where they are in their journey in recovery, connect with our patients to check in on them, to make sure they have the medications that they need, to make sure that they're not worsening. The precision recovery program allows patients to input their symptoms and meet with patients and do some screens of a review of systems, asking them, do you have any of these kinds of symptoms that have developed? So just having a plan in place on what you're going to do for those patients with chronic conditions with COVID-19, um, pre-existing chronic conditions, and then what are you going to do for patients who develop COVID-19 and have persistent symptoms. And just having a plan and a plan of escalation, I think, is the right approach.
So you actually addressed several important issues. So specific ones about monitoring of patients after anticoagulant treatment, and you mentioned the D-dimer, and use like oral anticoagulants, and it's more or less safe. You also mentioned about like doing radiology screening after the discharge. Are there any specific protocols have they been developed, or everything is ad hoc? You mentioned it's a personalized. So you're dealing with each specific question. You basically devise a specific plan that tailor to specific question, or you have general protocols or recommendations that you can follow up.
Almas, that's a very important question that you ask, because pre-COVID-19 we had a lot of different kinds of protocols. Um, as a neuro-intensivist, so my subspecialty, I deal with patients who come into the ICU with strokes, for example, and then we saw patients with COVID-19 and strokes. So what we ended up doing for those patients, we had all of these protocols for stroke follow-up already, specifically for COVID-19 patients, understanding whether they screening them for any of these other problems that I mentioned, PTSD, depression, anxiety, by way of either questionnaires or having a screening, either by way of self-report or during their outpatient follow-up. Several of these patients also, they came to our ICU and are being followed up by, for example, our cerebrovascular neurosurgical team, our stroke neurology team. They also have a cardiology team, making sure that when we see this patient in the critical care recovery clinic, we do all of that screening. We're asking them all these different questionnaires for depression, PTSD, anxiety, insomnia, fatigue, so on and so forth. Then we forward that information to their subspecialists. So their subspecialists are also aware that this person is feeling depressed and may not take their anticoagulant, or despite having underlying atrial fibrillation, or that they're so fatigued and they don't have any psychosocial support, that they're not going to be able to refill their medications. But identifying those challenges, that's why the role of social workers, case management, etc. So we had this pre-COVID-19 protocols for all these, a lot of different types of follow-up already. And now we're really shifting our focus a little more towards this personalization. Yes, we're going to follow all of our protocols, but also tailor our follow-up care to meet those specific types of new needs that these patients are developing, also in the context of social distancing. Or people may have lost their jobs, or their care provider, the person who was supposed to be their primary caregiver doesn't have a job anymore. So those psychosocial needs of patients, in addition to that layer of additional layer of medical surgical support that we're providing our patients, I think we just have to be uh, very careful, particularly for all those patients who have chronic conditions. The other thing that we noticed, and this was a little more heartbreaking, there was like a silent pandemic that was happening while COVID-19 was happening, and the NEGM had some good papers on that. There were patients who delayed their care for diseases that were absolutely treatable, because they were scared of coming to the hospital because they thought they might get COVID-19. And I myself took care of some of those patients, and I wish they had just come earlier to the hospital. But having said that, the burden of having missed their appointments, or having not been able to refill their medications, or having had to postpone an elective surgery, like, despite not having COVID-19, I think those patients are also requiring additional support. And therein, the expansion of telehealth resources and coming up with new protocols. So the protocol addendums that we did for all patients, whether they had COVID-19 or not, was if someone's coming in for elective procedures, if someone is coming into the clinic to be seen, what kind of screening are they going to need, and then what kind of PPE do the frontline providers need, and then also having a pathway of transition from, for example, a pre-op setting to the operative setting to the post-op setting, etc. So we had to change our protocols for care management, and then we also added this layer of precision of personalizing care.
So basically, you taking advantage of the existing protocols, but you have a challenges of tailoring to specific patient, not only his somatic situation, but also social conditions, so to speak. So,
Absolutely.
Dr. Dangayash, you mentioned at the beginning that you extensively use pulse oximeters, and some of them are remotely monitored. So, would you recommend all patients who recovered from COVID-19 to use pulse oximeters, meaning at Mount Sinai? And what are the cutoff points to determine if patient needs oxygen therapy?
So that's a slightly difficult question to answer because our approach has also been driven by having access to some of these resources. And I don't know how many, there are very few remote patient monitoring programs, even in the United States. So having said that though, we're not sending all COVID-19 patients with pulse oximeters at home. But a lot of patients just buy pulse oximeters off the market because they're just available. Some patients with chronic lung diseases already have pulse oximeters at home. So again, this theme of if you already have it, by all means use it. It's not something that we recommend that every single patient with COVID-19 gets discharged with. But if they start developing symptoms, if they're getting short of breath, then that absolutely needs to be checked out. And then not just checking your pulse oximetry at home, then, but having a way of escalating your care, whether it's contacting your PCP or whether it's going to urgent care or an emergency room, etc. So from that question to what kind of escalation do we need to do for providing oxygen support? So this has been fairly controversial in literature. I'm sure you've seen the arguments for the happy hypoxics, that those patients who can tolerate
Right.
hypoxia should not be intubated early versus those patients who should be intubated early. My read of this literature, COVID-19 is not a uniform disease process affecting the lungs. Whether it's with oxygenation or whether it's this subjective sense of dyspnea or hypoventilation, or shunting, there are lots of different ways in which COVID-19 is affecting patient lungs. Right from causing the kinds of features that you would see in a patient who has pneumonia, to the kinds of features that you would see in a patient with acute respiratory distress syndrome, to those kinds of patients whose lungs look relatively okay, but they're also very hypoxic. And the hypothesis there is because COVID-19 is causing inflammation of blood vessels, then there might be small clots that are forming within the lung. Then there are those patients who develop big clots within the lung, or PE. So they're forming big PEs in the lung. Then there are also, and we've discovered something at our hospital as well. One of our colleagues was incidentally doing Doppler studies, transcranial Doppler, so essentially looking at blood flow in the brain, and found all these bubbles that were going from that were detected in the bloodstream all the way up to the brain. Now, typically, our lungs are meant to filter some of these bubbles out, but when the blood vessels of the lung dilate, at that time, some of these bubbles can pass through. So then this shunting
Mm.
uh, is probably increasing in some COVID-19 patients. So my response in how do we manage oxygen support for COVID-19 patients goes back to understand what is the
It's causing.
problem with the lungs for the patient. And very often we're going to see a combination. And the second thing to keep in mind is the trajectory. So when do patients actually worsen? And at what point in time do we anticipate that they're going to have that worsening? So that cytokine release syndrome, or this cytokine release storm, we're typically seeing around days 8 to about 11. So monitoring your patients closely, looking at that trajectory, identifying what is going on with the lungs, whether it's a primary infiltrative problem, is it inflammation, is it infection, is it more clotting, is it a combination. Having said that, there will be some patients who will tolerate lower oxygen levels, but not all of them. So my in my own practice, I tend to be very data driven. So the more data, more information I have, the better my decision making is going to be. So I'm not just going to rely on one number. I'm not just going to rely on one image. I'm going to monitor my patients multiple times during the course of a day, and in an ICU setting, and multiple times over the course of several days, including this multi-pronged approach. In this multi-pronged approach, clinical examination, radiological, using non-invasive testing like point of care ultrasound to assess the lungs, the heart, and putting that whole picture together, doing checking for some markers, or looking at a panel of inflammation like the interleukins, or looking at some non-specific markers of inflammation like CRP, or looking for how prone is somebody, what is the risk of somebody forming clots. So monitoring all of those things together, I'm going to come up with, how do I risk stratify? Is my patient going to get into trouble or not? Support. And that non-invasive support, high flow nasal cannula emerged as a very helpful. I was using high flow nasal cannula quite often in my practice even before COVID-19. So I I personally think it's a very important tool in our armamentarium to try to take a patient through without the need for intubation. Sometimes patients may just need that additional support and they might get by. And we had patients who did that. And then there were other patients who, no matter how much supplemental oxygen you provided them, they just crashed. And when they crashed, when you were intubating them, it wasn't like you had a lot of time. Their oxygen levels just dropped, and you had to put them on a breathing machine right away. So in summary, I would say just coming up with a personalized approach and keeping a critical eye on literature, not going with one wave of opinion after another, will help us provide the right care to our patients. And using all those pre-existing protocols that we already had, evidence-based protocols for providing care for patients with ARDS, we should not abandon them for COVID-19 patients. We should very well use them, implement them in a way that makes sense for the patient in front of you.
Okay, so a few months ago, University of Oxford scientists released data that indicate that such inexpensive steroid as a dexamethasone is able to dampen the entire immune system, thus helping many severely ill COVID patients to recover from cytokine storm. So moderate doses of dexamethasone cut death by 1/3 among patients on ventilators. Mildly ill patients didn't fare any better than given steroids. There was a trend toward worse outcomes. Based on a clinical experience, how effective is dexamethasone?
So even before the recovery study from Oxford was released, it's a very well conducted study at the height of a pandemic. So it's a very applaudable effort on part of a lot of investigators. So even before this study, as part of our treatment, we were using steroids, but we were using solumedrol. There has been some description now in the literature about solumedrol or methylprednisone also providing some benefit in COVID-19 patients. So my current approach to steroids is essentially, irrespective of what you're choosing, whether it's decadron or solumedrol, uh, choosing the right patient who's going to need to be on steroids. Like you mentioned, in patients who have mild disease, they might not benefit, and there might be some potential harm from steroids. And that harm could include some superimposed bacterial infection, or their glucose control may go completely out of hand, particularly in patients who have diabetes already. So being careful about not using steroids in patients who have only mild symptoms. But if a patient with mild symptoms is beginning to develop moderate symptoms, their oxygen requirement is increasing, then add the steroids. And even early use of steroids, not late use of steroids. So what do we mean by this sort of early? So different papers have sort of looked at different time frames for when you should start it. But in the recovery study, using how they did it, and they were using decadron 6 milligrams for 10 days. I think it's a good protocol. When we were doing our solumetrol methylprednisone dosing, we were doing it for 5 days, but only early in the disease course. So if somebody came, uh, right from like days 5 to about days 10, 11, or 12, that's the period that we were putting people on steroids for. However, knowing that inflammation is what we're if that inflammatory phase in someone's COVID-19 disease is beginning to worsen, and you're seeing different effects on different systems of the body of that inflammation, thinking carefully about whether that patient is going to benefit from steroids at that point or not. Just asking that question, we know there's benefit, but then monitor for any secondary complications of steroid therapy, which includes superimposed bacterial infections or glycemic control, muscle weakness for patients who are already on sedation, on mechanical ventilation, and paralyzed. We know that when you use steroids in those patients, they may have a higher risk of developing critical illness, polymyoneuropathy. So keeping that in mind, and monitoring patients for development of complications, as long as you're doing that simultaneously with using steroids, they showed a very good mortality benefit. Steroids was showing that it can save lives. And the other therapies, so using not just one therapy, but using, because it's a multifaceted disease, using a bundle of therapies and preventative strategies that will take your patient with COVID-19 through is important.
So, given all these risks and challenges in using steroids, although it's extremely beneficial as you described, how about non-steroid anti-inflammatory drugs? Could they be as somewhat alternatives to dexamethasone? So, would you recommend to use them in a post-COVID state if you see increased C-reactive protein, for instance?
I think there's been it's a little challenging to extrapolate the information that we have gotten from the benefit of steroids to non-steroidal anti-inflammatory drugs. The other problem that also happens, these patients also had acute kidney injury, and they also had problems with their liver function. May not Very few patients developed problems with their liver function to the tune that they actually had acute liver failure, but there was definitely liver injury and there's kidney injury. And kidney injury, we know that there are patients who are requiring dialysis, not just in the short term, but potentially they might become dialysis dependent as well. So I think keeping that in mind, extrapolating, unless there's a clinical trial setting that we're going to figure out whether non-steroidal anti-inflammatory medications should be used long-term or not, or I would advise caution there, specifically because COVID-19 is a multi-system disease, and you might end up causing harm and not see any benefit.
So, Dr. Dangayach, you mentioned a little bit nutritional support program. So, are there any natural ways to stimulate immune response to coronavirus and to calm it down without the use of drugs to prevent or avoid, as you described, cytokine storm? So, do you think that are there any diets or supplements that could replace some of those vicious drugs that that could harm the patient?
You asked such an important question. Nutrition therapy, just understanding the role of nutrition in in allopathic medicine as a whole. I think we're beginning to understand a lot of things about anti-inflammatory diets, or understanding how to build that reserve so you can fight off infections, whether it's incorporating protein in your diet, or if there's a higher risk of cardiovascular disease, then using a Mediterranean diet. And the Mediterranean diet also has some anti-inflammatory properties. And traditional diets, the diets that are not based off of packaged foods, you take something out from the freezer and you just microwave it. That's I almost feel like what I have learned from COVID-19, all those good practices that we had pre-COVID-19, the ways we thought we could promote health and prevent disease, all of those things apply so much more in the COVID-19 era as well. Whether they specifically help prevent COVID-19 or not, that's not really known. However, they are going to overall promote health. So whether it's exercising, whether it's eating fresh fruits, vegetables, leaner meats, incorporating fish in your diet, the dietary supplements, and it's fairly controversial what dietary supplements are needed. But if somebody has a deficiency of a particular vitamin, or a particular um, or a particular element like iron, those patients should absolutely take those supplements. But just taking things over the counter, thinking that something's going to work to fight off COVID-19, I would advise caution there, because we have to be very careful and that's also something we have seen in the medical world right now, where all these different kinds of medications, people started using some of these medications outside of any clinical trial setting, and whether they helped our patients or whether they harmed our patients. I mean, that's something that's also true for nutrition and food, because food is as much a drug, as much a medication
Yeah.
as what we think of as traditional medications. So I would say we've got to be thoughtful. We should not try taking supplements that we would not have otherwise taken. Taking a multivitamin tablet because you think your own diet is not giving you all the nutrients that you need, absolutely, then take that multivitamin. I think that's fine.
Okay. So my last question. So it is August now. September is coming, and October is almost in our backyard. So assuming the flu season is coming this fall, would you recommend post-COVID-19 patients getting flu shots? Would protect healthy individual from having a double infection of flu and COVID-19?
And for preventing this double infection, yes, we are all going to be at a risk of developing this kind of double infection with COVID-19 and flu, and there are similarities, there's an overlap in the symptoms, and we might not be able to fully tease out which disease is driving a patient's clinical trajectory. But having that co-infection, whether it is going to increase mortality, whether it's going to increase the risk of being on a breathing machine or mechanical ventilation, that remains to be seen. But my advice would be, don't wait to experience both the infections. Rather, something that we can prevent, let's prevent it. So the flu we know can be prevented by way of a vaccine. A COVID-19 effective vaccine is on the horizon. There are so many countries. This is another blessing that we have seen from COVID-19 pandemic. So many countries across the world are collaborating and coming up with vaccine candidates. So once a vaccine is on the market, then also taking the COVID-19 vaccine to prevent an infection. COVID, where once you take the flu shot, it doesn't mean that you will not get the flu. What it means is that you will get less severe symptoms from the flu if you were to get the flu. So is the COVID-19 vaccine going to act in a similar fashion? We don't know yet. That needs to be seen. But my message to everybody who's going to listen to this would be, take the vaccine if you don't have any other contraindications, for your safety and for the safety of your community.
Okay, great. So speaking of messages, I have one hypothetical question. So Dr. Dangayach, should you have opportunity to write something on a huge billboard on Times Square, New York, to address COVID-19 pandemic? And what would you say to the people of New York? What would you write on that billboard?
Say hashtag in this together, and we have got to strengthen all our existing programs and collaborations to preserve health, promote health, and come together in a crisis situations, above all socioeconomic, racial, ethnic disparities and differences, and fight this disease together. I think that's what I would say. I think those are lots of words. I might have to pay a lot for that billboard.
But like the hashtag "well together" would be probably the most important.